Good evening, ladies and gentlemen. Welcome to the first webinar in PRODIGEE Pediatric Radiology Discussion and Expertise Exchange. I am Yogi. I am a junior radiologist in Pediatric Radiology Division in Cipto Mangunkusumo Hospital. So today I have the privilege to moderate this exciting session. I'd like to extend a warm welcome to our distinguished speaker, to Dr. Amal and Prof. Suranyi. We are very grateful to having you two with us today. Let me give you a little introduction about the PRODIGEE. It stands for Pediatric Radiology Discussion and Expertise Exchange. This is a platform that we built to help radiologists all over the country in dealing with pediatric cases, because we know it sometimes is quite challenging. And as a platform, we have engaging program ahead from webinar, case discussion, and workshop to advance our knowledge and collaboration in pediatric radiology. So today is our first step. We are starting from cardiac imaging. Into this webinar, we're going to discuss about the basic pediatric cardiac CT and interesting cases. Whether you're here to deepen your expertise or exchange ideas, I'm confident that in today's discussion, it will be enriching and inspiring for all of you. So before we begin, let me go over some housekeeping points. The first one, please ensure that your microphone are mute. And the second one, you can ask the question directly at the Q&A session, or you can type your question in the chat and we will read it in Q&A session. And the last one, please stay engaged and take as many as information that you can get. Without further ado, it is my pleasure to introduce our speaker. The first speaker is Dr. Amal. Hi, Dr. Amal. Yeah.
Hello, Dr. Yogi. Hello, Prof. Suranyi. Nice to meet you again.
Hey, nice to see everybody.
Yeah, Dr. Rama is my mentor in Cipto Mangunkusumo Hospital. So maybe we have a little bit introduction to Dr. Rama. Dr. Amal is already like through a lot of training in cardiac CT in USA, in Taiwan. So I think is one of the best. Is currently as a lecturer also in university in Indonesia. And our second speaker is Professor Paul Suranyi. Professor Paul is actually professor from the South Carolina Medical Center in United States of America. He has done the PhD in Alabama University of Alabama at Birmingham, and cardiovascular imaging fellowship CT and MRI in South Carolina Medical Center. So without further ado, let's go to the first presentation. It's from Dr. Amal. Dr. Amal, the time is yours.
Thank you, Dr. Yogi, for the introduction, and good evening, everyone. Assalamualaikum warahmatullahi wabarakatuh. Selamat sore in bahasa. I will try to share my screen. Today I will try to share about pediatric cardiac CT or protocols for CT imaging in congenital heart disease. Actually, this presentation will be like a sandwich with Prof. Suranyi. So before we're having a lecture from Prof. Suranyi about the technique of the cardiac CT, maybe I can share with sorry. Okay, yeah, I will try for the short introduction first. So why CT in pediatric cardiac, especially in congenital heart disease? Actually, in Indonesia, CT is increasingly being used for evaluating the cardiovascular structure and airways in the patient in congenital heart disease, not only in Indonesia, actually, in Asia. When I learned also cardiac imaging in Taiwan, and a lot of CT, they do a lot of CT for evaluating congenital heart disease, not only in Taiwan, in Malaysia, and also in Singapore. So recent developments in CT technology, primarily by reducing the cardiac motion and the radiation dose usage in congenital heart disease evaluation, have helped expand the indication for CT usage. And also not only CT, MRE, CT and MRI help clinicians to improve diagnosis for congenital heart disease, and especially can limit the need for invasive imaging procedure only for diagnostic. So in pediatric, we are facing a lot of or some challenges in pediatric cardiac CT. Not only we are facing high heart rates, but we are facing about the breath hold protocol. In adult, we easily to ask a patient to hold their breath, but not in patient in pediatric, and especially in neonates. So we don't have breath hold protocol in pediatric cardiac CT. And we are facing with a high radio sensitivity in the patient with pediatric, and also complex hemodynamics. And the most important things we also facing with immobilization. So we really need to have a really good preparation before we are using CT for evaluating cardiac imaging in pediatric patient. The first thing we need is patient preparation. Careful patient preparation is a prerequisite for successful performance of pediatric cardiac CT. So we need detailed procedural patient assessments, including age, body size, and also vital signs, oxygen saturation, and also renal function. Besides that, we need to know about the patient history and also the result of the echocardiography, so we can planning what we will use next for the technique of the CT scan. And in cardiac imaging, because the scanning time is very short, we can have a different type of patient preparation. For example, we can use sedation, really short sedation, and we can ask anesthesiologists to have a shorter time of sedation, especially only during the scan time. But sometimes in my hospital, if the baby is very small, or during neonates, we usually don't use the anesthesia. We will wrap the baby, and then we scan the baby without the anesthesia. So it will help us scan the baby without using the anesthesia. And how about the medication? For pediatric CT, we never use medication to reduce the heart rate. So we try to have technique in order to make a really good image. So all the chamber, all the great arteries, and even the coronary artery, we can see clearly without using the medication. And after the patient preparation, we also need the protocol for injection intravenous contrast. So the important thing or important point about the imaging in congenital heart disease is we need to see all the chamber all the great vessels and also the coronary artery. We need to evaluate all that things, and also we need to evaluate the airway also, because in some congenital heart disease patient, we will facing with malformation of the airway. So not only great vessels, intracardiac chambers, and we need also see and look other things such as airway and lung malformation. That's one of the important things we need to evaluate in pediatric cardiac CT. About the intravenous injection protocol, so the basic thing is we don't want our scan area it's limited because of the contrast artifact or even lack of contrast enhancement in the chamber or in the great vessels. So in my hospital, I usually use like a triphasic injection protocol. So in the first phase, I will use undiluted contrast agent. And then next phase, I will use like 60% of diluted contrast agents, and also the third phase, I will use saline chaser. So in order to reduce the contrast pooling in one of the vessel, usually the contrast pooling we can see in the superior vena cava or even in the innominate vein. So with the triphasic injection protocol, we can reduce the contrast pooling that can cause the contrast artifact that really bad for our evaluation in intracardiac evaluation. So not only about the injection protocol, we need also to look about the flow rate of the injection, and that flow rate it depends on the gauge, how big the gauge of the IV line. So in my experience, do not use flow rate below 0.8 milliliter per second, because we cannot see contrast clearly in the chamber or even in the great vessel. So minimum, it's the flow rate, it's 1 or 1.2 milliliter per second. Then we can use 18, 20, or 22 gauge of IV line, and the best use is put the IV line in the cubital vein, not in the wrist region or in the smaller region of the vein. Next, this is the example of how the biphasic or even triphasic injection protocol. In my hospital, we usually use triphasic injection protocol because our injection machine, we can setting into the triphasic. So the first phase, we will use fully contrast. Second phase, we usually use like 60% only contrast, or even we can use only 40% contrast. And third phase, we can use saline, or even we can add 10 or 5% contrast. So at least we will reduce the contrast pooling in one of the vessel. And the next thing we need to understand is about the machine that we have, because right now, for example, we have like 4 major vendors machine, such as Siemens, Canon, GE, and also Philips. But how we deal with this machine, we need to know about their technology, about the number of detectors, and even the Z-axis coverage. Because if we know the uniqueness of our machine, we can tweak our scan technique. For example, in our hospital, we are using dual source CT a lot for our cardiac pediatric. So we use techniques such as turbo flash in order to reduce our radiation dose. So, and it also helps with patient with the pediatrics, so we don't need rely on sedation. For example, if the patient we wrap the baby and the turbo flash is very fast, and even the baby will a little bit shocked when during the scan because it's really fast, and it's like the baby like little bit like hold their breath involuntary. So that's we will have a really good image on that. So that's very helpful if we know the uniqueness of our machine. And for example, if we have like a Canon with quite large Z axis, and we can like scan in one bit scan. So in order to make a really good image, we need also to understand and really know about the unique of our machine. And also sometimes we use spectral CT. We have like a spectral CT, and with the mono E, that's really helpful. We can reduce our iodine dose because in our pediatric cardiac protocol, we use like 1.5 milliliters per kg. And for a spectral, we can use half of that. So we can use 1 or even 0.5, but I usually use 1 milliliter per kg. And then with mono E, we can reduce the kV by post-processing, so we can see contrast enhancement clearly with the spectral CT. So with that both the CT, I can pick which one is the best for my patient. But first, I need to know about the situation of the diagnosis from the echo first. So what we need to look, and then I decide which one of the machine that the best to evaluate the patient. And next, about the scan technique, I will pass to Prof. Suranyi. He will give us a beautiful presentation and understanding and also animation about the scan technique. I will stop share and you can start share, Prof.
Thank you. Hopefully you can hear me.
Yeah. Clearly.
And I will go ahead and share my screen. And hopefully this works well. So thank you for the invitation and for including me in this pioneering process. This is fantastic. I'm very excited. And so I know we are going to review a couple of cases as well online. So we will try and, I think it stopped sharing for some reason. Yep. So the different cardiac CT techniques, and I actually grabbed this screen capture from Dr. Amal, as he was just talking about. And I will mainly be talking about the dual source, various ways of the dual source scanning modes. And believe it or not, there is already a so-called alpha scanner, which is a dual source as well as spectral. So it's including all of the best state-of-the-art technology. But the principles are going to be the same for all of these scanners. And in cardiac imaging, what's going to be very, very important, like Dr. Amal said, the two things to consider is temporal resolution. That's going to be one of the most important things. especially to visualize little hearts, younger hearts that are beating at a very high heart rate. And then the other important thing is the Z-axis coverage. And as I will show you the different scanning modes, sometimes you just zip through the patient in one sort of a flash, and at other times you slowly but smoothly move through the patient. And yet another scanning mode type is a step and shoot scanning mode. And I will have some little animations just to give you an overarching idea of the various ways of using CT scanner. Because it's not that easy that you just put the patient in the CT scanner, press a button, and there is your CT scan. Cardiac imaging is way more complicated than that. So there will be 5 major ways of scanning the chest, or sometimes we even have to include the upper abdomen for some of the vascular abnormalities in these patients. You can just get a regular routine CT scan. And if you're really only interested in the descending aorta, you're mainly just following a child who had, let's say, vasculitis, or a young person, and it's really a middle aortic syndrome or something like that, you might be able to get away without cardiac gating even. We're obviously not going to talk too much about this, but this is one way of using a CT scanner. It's a regular spiral scanning. The next way is the ultra-fast spiral scanning, which is really only available with the dual source scanners, because there you can speed up the acquisition, have a fairly high temporal resolution. But what's important to note here is that we will not have very good EKG synchronization. So while we are zipping through the chest very fast, we don't really have control over what phase of the cardiac cycle we are in. And you will learn as you get deeper into cardiac imaging that whenever you want to measure anything in the heart or assess anything in the heart, the cardiac imager has to keep in mind at what phase of the cardiac cycle were our images acquired. So that's going to be important to keep in mind throughout the talk. And then there is retrospective gating, which is a very slow scanning, continuously scanning through the patient, while at the same time acquiring the EKG and putting the images together retrospectively, looking back at the imaging data and looking back at the EKG data and piecing the data together that way. This scanning mode gives us full cardiac cycle visualization, and it's excellent for evaluating function and valvular structures as well. The fourth mode is the step and shoot prospectively triggered or sequentially triggered method, where you get very nice frozen images of the heart if you time it to the right portion of the cardiac cycle. We'll talk about that a little bit more in a second, but you do not get any function. So if the patient has a good rhythm and relatively slow heart rate, or even if it's just very regular but fast heart rate, as we will see in some of the examples in kids, you can get pretty good views of the coronary arteries, at least proximally, to look for anomalous coronaries or something like that. And then the last mode is the so-called adaptive sequential, where what you're doing is a step and shoot method, but each time you're stopping and shooting, you're gathering more information to cover a portion of the cardiac cycle, maybe not all of the cardiac cycle, but a portion of the cardiac cycle that will allow you partial evaluation of function, partial evaluation of wall motion, and valvular function as well. So a full retrospective scan will include the entire cardiac cycle, right? Let's really briefly review the cardiac cycle here. The cardiac cycle in our world, in radiology, will span from R wave to R wave, because that's what we use for triggering most of the time anyways. And then it's important to note that when the R wave, the QRS complex hits, that's actually, that coincides with end diastole, because that is electrical systole that signals the heart to start contraction. The heart will start first with isovolumetric contraction, then ejection happens, then we reach end systole, the lowest left ventricular volume time point. That's going to be an important time point. And then there's going to be passive filling of the ventricle. And the patient enters the mid-diastolic standstill, which is going to be very important for us. And then finally, the cardiac cycle will end up with the atrial kick, atrial systole, which is initiated by the SA node usually, and then with a little delay, you get an atrial kick as well. So that's the basis of our cardiac cycle. So let's zoom in on this a little bit more. And in cardiac CT, there are two ways you can orient yourself within the cardiac cycle. One is by milliseconds or by percentages. So a lot of the times, for simplicity's sake, we divide up the cardiac cycle into percentages. And in that sense, 0 would correspond to the QRS complex, 0%, which is end diastole. That's when the heart is, the ventricles are most full, and the signal for contraction starts. You have isovolumetric contraction. The heart starts to contract, the ventricles start to contract, but there's no ejection yet. Then ejection happens. You arrive at end systole, the lowest point in ventricular volume. Then there is isovolumetric relaxation. So there's also a very important time point here at end systole when the heart is not moving a whole lot. It's isovolumetric. The volume is not changing. Therefore, the heart is not moving as much. Therefore, we can visualize small structures well. Then there's fast passive relaxation, not a good time point to image. But then in the mid-diastolic standstill, again, there's a good time point to image the patient because the heart is waiting for the SA node to kick and that atrial kick to follow. So our two sweetest points in cardiac imaging are going to be right around 40% and right around 70% of the cardiac cycle. The end systolic phase and the mid-diastolic standstill. For some reason, usually the isovolumetric contraction near end diastole is not as good a phase for us. So we will sometimes refer to these as best diastolic and best systolic phases as well. Now, obviously, you remember from medical school and physiology that the cardiac cycle and the filling processes depend highly on heart rate because it turns out that our systole is relatively stable, but diastole is very variable. So the mid-diastolic standstill will only be present if our heart rate is less than 70. And those of you who do pediatric imaging, you will know that that's rarely the case. Therefore, it's very important to focus on the end systolic phase if we're getting only one image, or if we're using two current modulation, that we get our best images at end systole in patients who have a heart rate higher than 70. Notice also the difference between these two shapes of left ventricular volume curves. Look at this orange curve. I'm going to go back to heart rate less than 70, back to heart rate over 70. Notice that this mid-diastolic standstill disappears. So there's no point in imaging during the diastolic filling because the heart will be relaxing continuously and it will not give us good images. So fast heart rates, remember that 40% of the RR interval is going to be our best time point, or which is, you can also set in milliseconds, roughly around 300 milliseconds. Or 250 milliseconds from the QRS complex. That's just an aside note. Now, the first thing I'm going to show you is a routine scan spiral. It's non-gated, so the heart will be beating, right? And you heard the sound effect maybe. I don't know if it was shared on Zoom, but that's just showing you that the radiation is on. Notice that we will have lots of motion artifacts at the level of the great vessels, not even mentioning all the motion in the heart. This will be not a proper evaluation for any of our patients with intricate small VSDs or ASDs or faulty valves or anomalous coronaries. So this is not going to be useful for us. The only structures that can be really evaluated are maybe the descending aorta and abdominal organs. So we're going to skip over this quickly and show you the fast, ultra-fast spiral scanning. which is a quick way of scanning the patient. It's still spiral scanning. We don't really have control over the cardiac cycle, and as you see, the heart is beating while we're scanning through the patient, but we're scanning through the patient super fast. This super fast scanning, which is only available in dual source scanners, will also allow us not just fast scanning through the patient, but fast scanning in terms of temporal resolution. So our temporal resolution is right around 70 milliseconds. That allows us to freeze the motion of most of the great vessels, even sometimes the proximal coronary arteries, especially if the patient's heart rate is slower. There is one trick you can do, and that is to do a triggered flash scanning. So as you see here in this animation, pay attention to the EKG, then the trigger hits, then we scan the patient through very, very fast. This allows us, if we're smart and try to time our imaging, that most of our scanning at the level of the coronaries will happen in the mid-diastolic standstill. So that would be a very useful way of using this, and you might be able to catch the coronaries even with flash scanning, at least the proximal coronaries. But we will have to remember that this sort of EKG triggered ultra-fast spiral is still not ideal for the coronary arteries. So the flash scanning mode is going to be super good for very small babies with relatively very high heart rates. If your primary interest is not so much the coronary arteries, but the rest of the physiology or the rest of the anatomy and the great vessels, pulmonary veins, aortopulmonary collaterals, that's going to be a very helpful and relatively low radiation dose, high resolution scanning mode. It's also helpful in following up patients with postoperative changes, even the great vessels, even closer to the heart. But if you're really, really worried about the coronary arteries, and you really need to look at valvular function, or you need to look at cardiac function, then you will need to get some of the other scanning modes. And remember that the flash scanning mode is going to be suboptimal for coronaries. Let me show you the next one. Notice that here the radiation is on constantly. It's a lot of radiation. This is also spiral scanning. This is retrospectively gated. So we're scanning through the patient very, very slow, continuously irradiating the patient and recording the EKG. Thereafter, the images are compiled by the computer retrospectively, and the full cardiac cycle is reconstructed. Remember, this is a lot of radiation. That is the cost for getting a lot of information. We get the full cardiac cycle. We can look at valves. We can look at artificial valves and devices, and we can even see, like in this case, you can see a little clot with this artificial bileaflet valve. And really, what you need to do is retrospective gating in patients with bad arrhythmia, right? So you will, and in that case, that's more advanced, but you can even edit the EKG retrospectively and throw away some of the oversampled data from faulty heartbeats. And even patients with very irregular heartbeats can be imaged this way. Again, remember, this is a lot of radiation, but it gives us the most information of the entire cardiac cycle. So if you're really interested in valvular disease, to fully image all of the opening and all of the closing, looking for stenosis and prolapse, for example, simultaneously, you need to get the full cardiac cycle, and therefore you do need to get retrospective gating. The fourth method is a step and shoot method. We will not get function. This is prospectively triggered acquisition, sequential or axial scanning. This is not spiral scanning, remember that. So we will trigger, and if the patient's heart rate is slow, then we will aim for the mid-diastolic standstill at about 70% of the cardiac cycle. Then we move the table, we skip through a heartbeat or two, then we trigger again, scan some more, and here the z-axis coverage is going to be very, very important, because depending on how much z-axis coverage you have, you may be able to scan, and what size the patient's heart is, you may be able to scan the heart in one heartbeat, like with some of the other scanners, not dual source scanners, but a lot of Z coverage. Or with some of the dual source scanners, you can cover the heart in 2 or 3 or 4 heartbeats, depending on the size of the patient. But nonetheless, this is a step and shoot mode where if there is not good rhythm, or if there is patient movement, you might end up with misregistration. Let's look at what this looks like in practice. You will probably see a sound effect again. So you see step and shoot, and every time you hear the buzz, there's some radiation. I'm going to show you this animation one more time because it's very helpful, I think, to see and envision. Step, shoot, step, shoot. And you see up here that we are acquiring the data sequentially. This is not spiral scanning. And the downside of this, if you have arrhythmia, could be misregistrations amongst the slabs. The other downside is that the scanning time might take a little bit longer, or will definitely take a little bit longer if you have multiple slabs, and your contrast injection might be running out. So you might have non-uniform contrast opacification throughout your slabs. So those are the downsides, but this is relatively low radiation, and if the patient has regular rhythm, then it's an excellent way of looking at ascending aortic disease, pulmonary arteries, coronary disease, looking at anomalous coronary arteries, and even rule out reasons for chest pain in young people. Very important, good way of evaluating the pulmonary veins as well. Rhythm is paramount, is absolutely crucial in this particular scanning mode. And the last scanning mode is going to be this adaptive sequential, which is again a step and shoot method of scanning, but every time we step, we cover a bigger portion of the cardiac cycle. We're not just getting one image at a time point, but we're getting multiple images at that slab, at that level, to get some cardiac functional information that's going to provide us perhaps with systolic function, perhaps with limited evaluation of the valves, but some function, and also gives us multiple images for the coronary arteries in case we are worried that we run into some motion artifacts and we need a couple different phases of the cardiac cycle to really decide if we're dealing with an anomalous coronary artery or if we're really dealing with a compressed coronary artery or a stenotic coronary artery in older patients with atherosclerosis. So at our institution, we typically do this scanning from 30 to 90% in an effort to include both the end systolic phase right around 40%, the mid diastolic phase right around 70%, and getting close enough to the end diastole, which would be right around that 100%. So this way we can actually get cardiac function as well. So what does this look like? A longer scan followed by a step, longer scan. So our step and shoot is sort of the same, but every time we stop the patient, as we're moving the patient through the gantry, we're going to stop for a longer time and scan and radiate them for a longer time. So that would be the summary of the different scanning modes. And the only other additional thing that I would add to this is that it's important, if you're using one of the scanning modes where we're getting more information through the cardiac cycle, you may want to add that 2-current modulation if that's possible with your scanner, because that way you can reduce the radiation. And just remember, I'm going to show you this one last slide, that if you're not scanning the full cardiac cycle, you have to be very careful, especially when evaluating the valves. If you look at this artificial bileaflet valve, it looks like this valve is not moving. Yet the heart, the left ventricle, is contracting. So is that compatible with life? It wouldn't be. So this is an artifactual issue here with acquisition, and this is why it's important to understand your acquisition, because this aortic valve does not appear to be open because we scanned diastole. The aortic valve closes at end systole, and though we scanned all of diastole, the aortic valve should be closed in diastole, and that's exactly what we see. We see a little blip as one of the leaflets was just closing near end systole, and then the rest of the images are all diastolic images. And even though if you play it as a loop, it gives you the appearance that you have a full cardiac cycle, in reality, you do not have the full cardiac cycle, but only from 30 to 100%. So this is where I will hand it back over. Thank you for your attention, and let's look at some cases with Dr. Amal.
Hey, thank you, Professor Paul. Professor Paul. Okay, the next we will proceed to sharing of the case, and we're starting from Dr. Amal. Dr. Amal, are you ready?
Yes.
Yeah, okay, Dr. Amal.
Thank you, Prof. Okay, for the first case, I think in line with the Prof about the technique of the scan, I will share about the turbo flash case that we scan. Okay. Can you see it, Dr. Yogi?
Yeah, I can see. The slide is clear.
Okay. Yeah. The first case is case that we scan the patient with the turbo flash. So as the Professor Suranyi mentioned, we cannot make a control about the phase, what percentage that we really want, but we try to predict from the ECG gated. So this is the gated turbo flash that we made for the patient with the heart rate around maximum is 120, and for the average 140. And the important thing about this turbo flash is we can have very low radiation dose, around only 8 milligray centimeter, and with the image I will show you. Okay, I will make it. Okay, I will show through the axial scan. Is it moving, Dr. Yogi?
It stopped now, but it's actually sometimes it's moving.
Okay.
We can see
it's
your
moving now.
mouse. So it's, yes.
Okay. Okay, I will try to scroll from the cranial. So as we can see in here, with the injection protocol, with the 3-phase injection protocol that we use, we can see very clearly about the contrast enhancement in the intracardiac chamber and also in the great vessels. And also with the turbo flash, sometimes we can capture really good image of the coronary artery, ostium of the coronary artery, and the proximal of the coronary artery, and the course of the coronary artery into the distal. But be careful, as Prof. Suranyi mentioned also, if we have like a bigger baby, it's really difficult if we use this turbo flash, because the image also not really good. So I'm using this turbo flash for a patient actually be for a neonates, and also for a patient with the important evaluation. If we need to know about more coronary artery, I will not use the protocol of turboflash, but rather I will use retrospective ECG. So we directly see about this patient anomaly. As we can see here, we can see this is right superior vena cava, and this is left superior vena cava. As we can see here, this left superior vena cava goes into the coronary sinus and into the morphology of right atrium, and also with the right superior vena cava drains into the morphology of the right atrium. The morphology of right atrium with the broad base of the appendage, and this is the typical of morphology of right atrium. With this is the inferior vena cava. We can see in here also drains into the morphology of right atrium. In here, we also need to evaluate about the pulmonary vein. In here, we can see all the pulmonary vein drains into the morphology of left atrium, and there is no stenosis in the pulmonary vein. So with the configuration, morphology right atrium in the right side and left atrium in the left side, we can clearly say this is the atrial cytosolitus. Next is we need to evaluate about the interatrial septum. As we can see here, there is a defect, small defect in here. This is showed about the ASD. So this is the ASD secundum. Next, we need to evaluate also the valve. So atrioventricular valve in here. We need to also see about the morphology of the ventricle. In here, we need to careful look about the ventricle. As we know, the morphology of the right ventricle is very coarse, not like left ventricle is very smooth. And also right ventricle, we can see a moderator band. In here, we can see this chamber is very coarse, and also we can look, this is like a moderator band. And the most important thing is when we look the outflow tract of the ventricle, usually if we see the left ventricle and goes into the aorta, we can see a fibrous continuity between the mitral valve and aorta. But in here, we don't see any fibrous continuity, but we can see this is a very thick, we call it the infundibulum. So this chamber is not left ventricle, but rather this chamber is right ventricle morphology. So this chamber with the smooth morphology, this is the left ventricle. So when we see this patient, this outflow tract from this morphology of left ventricle goes into the pulmonary artery, and this morphology of right ventricle goes into the aorta. So this case, it's transposition of the great artery. It's a type of CCTGA with the ventricle L loop, that the pulmonary artery comes from the right morphology right ventricle, and aorta aorta comes from the morphology right ventricle, and pulmonary artery comes from the morphology left ventricle. And also after that, we need to evaluate about the great arteries in here. In here, we don't see any PDA. It's better to see the PDA usually in sagittal. Yeah, in here, we don't see any PDA in here or even MAPCA. And also we don't see any stenosis in the aorta, that's signs of coarctation aorta. And also we need to look about the condition of the branch of the subclavian artery. Is there any aberrant subclavian artery or not? But in this patient, we don't see any aberrant subclavian artery. Next, we need to check also about the pulmonary artery. In here, we can see the right pulmonary and left pulmonary arteries confluent and without the stenosis. Finally, we need also to check about the airway. Do not forget about the airway because some of the patients with congenital heart disease also have malformation in the airway, but this patient, we don't see any malformation of the airway and no stenosis of the airway. So in conclusion, this patient have image with the CCTGA. And that's for the patient number 1, Dr. Yogi. And how about Prof. Suranyi, do you have any comment about this patient?
I don't have any comments. This was a beautiful presentation. If you want to show your other case, I think we have some time, and then I can show.
I will share for the next case. Wait, I will stop share first. Okay. Okay. Yeah, this is the next case. I want to share about the technique that we use for this case is retrospective ECG gated. As you can see in here, we have like 0%, 40%, 70%, 75%, and even non-gated image. So this is we use retrospective ECG gated, but the disadvantage of this patient is the radiation dose is very high. When we compare with the turbo flash is on the 8, and with the retrospective is around 200, and this is very high. So that's why we need to carefully look what we really need to have for our patient and which technique that we really need to use. And this patient tells us, I will share with the 40%, will show us about the partial anomalous pulmonary venous drainage in here. As we can see, this is the, I will make, okay. Yeah, this is the pulmonary vein in here. This is the lower right pulmonary vein, and this is left pulmonary vein, left upper pulmonary vein, and left lower pulmonary vein. it drains into the coronary sinus. So we have dilated coronary sinus in this patient, and also dilated morphology of right atrium. But the other pulmonary vein, like right upper pulmonary vein, it drains into the morphology of left atrium. So this case show us about the pulmonary PAPVD, pulmonary anomalous venous drainage. So in here, yep, this is the anomalous drainage of the pulmonary vein into the coronary sinus. So this patient anomaly is PAPVD, and I think this is the one that I want to show about the case of a retrospective ECG gated Prof. Suranyi. And I think we have a case for a prospective Prof. Or do you have any comment about this case?
Yeah, no comments. Beautiful, beautiful scans,
Okay.
beautiful pictures. I will show a couple prospectively triggered cases then here.
Stop share. Okay.
And I will try to share my screen. So this first little baby is really little, as you can see. It's just I believe it's a 1-day-old little boy. And I would like to highlight here on our technique page that we actually did adaptive sequential. So, and it's a little bit misleading because when you're doing this prospective step and shoot technique, you can actually dial it down all the way to a single cardiac phase. So even though we did not get any functional data on this little boy, we were able to image the coronary artery origins at relatively high heart rate. And I'm gonna, with the interest of time, I'm gonna quickly go over the findings here, trying to follow Dr. Amal's lead and going from top to bottom. Just remember that we're really zoomed in here, and we used very little radiation. I don't know if I showed this, but the DLP is 3 here in this case. Really minimal radiation exposure to this young child. So we come from the top of the chest. We can immediately see that there's a right aortic arch with an aberrant subclavian artery, which is retroesophageal over here. Otherwise, the arch branching pattern is as expected with a left aberrant subclavian artery. So right-sided arch, we're scrolling down. We only see a single right-sided SVC. And then as we get to the level of the proximal aorta, we see that next to the aorta, there are these tiny, tiny pulmonary arteries. So they're very, very hypoplastic. And as also confirmed by echo, there was no communication between this hypoplastic main pulmonary artery and the outflow tract of the right ventricle. So this is pulmonary atresia is what we're dealing with. The right ventricular outflow tract is completely obliterated by muscle, and there's no identifiable pulmonic valve. This other structure you see next to it is the appendage, the left atrial appendage. So I don't want you to be confused by that. That's not a pulmonary vein. This is a left atrial appendage. The pulmonary vein is right next to it here. And it seems like the appendage is left morphology. And so therefore our left-sided atrium is truly a left atrium, and we can see other pulmonary veins. And so the pulmonary venous drainage is normal. We have a left atrium here. We do have a communication in between the atria, so we'll keep that in mind. in a very, very young child, that's very difficult sometimes to tell whether this is a secundum type ASD, or is this just a PFO that's that kept open because of elevated right-sided pressures. So sometimes we even hedge on that, and we'll follow up with echo typically, and then they can decide for sure whether it's a secundum type ASD or just a PFO. But nonetheless, there is a communication here between the atria. We see a morphologic left ventricle that looks fairly normal sized, as you would expect. And as you come toward the outflow tract here, you can see that there's an outflow VSD fairly large, and that our aortic valve is overriding the ventricular septal defect and the interventricular septum itself. We also can appreciate that our right ventricle, the muscle in the right ventricle, is almost as thick as the left ventricle. The trabeculations are prominent. The moderator band is very big. So we can surmise from this that there is some right ventricular hypertrophy. And I'm sure a lot of you already put it together that this kid has tetralogy of Fallot with pulmonary atresia and very, very hypoplastic pulmonary arteries. And then we also see some additional funny looking vessels coming from the descending aorta here that are, this is our subclavian here. So I'm coming again from the top. This is our aberrant subclavian, but as I'm scrolling down further, watch the descending aorta, and we have this one major aortopulmonary collateral artery, which may in fact be a glorified bronchial artery that just got very, very big. Nonetheless, this would be one major aortopulmonary collateral, and there's another one here that you can see. So we have several major aortopulmonary collateral arteries supplying the lungs with blood here, because this kid is has pulmonary atresia, and we cannot really identify a true ductus in this patient. So this patient cannot be ductus dependent, because a lot of our patients with pulmonary atresia would be ductus dependent. This kid is going to be dependent on these major aortopulmonary collateral arteries. And let's go on to the other case that I wanted to show that's similarly performed in a very young child. It's a couple weeks old, this child. Again, look at our technique. It's a sequential scanning, so this is not spiral scanning, not retrospective scanning, not a ultra-fast spiral scanning, not a flash scanning, but we actually tried to synchronize the acquisition as a step and shoot manner, in a step and shoot manner. We did not get any function, just a single cardiac phase right around 40% of the cardiac cycle. If you can see up here, it actually says 40%. So we aimed for the end systolic phase in this child. The DLP was 2 only, so very, very low radiation and fairly decent diagnostic quality images here. Lots of findings. As we're scanning from the top, we can see normal arch branching, left-sided arch, but this arch is very, very, very small. I'm going to MIP it a little bit just so you can appreciate how small this arch is. This is our aortic arch here. This other thing that we see here is a ductal arch. On echo, they would call it a ductal arch, which is an enormous patent ductus arteriosus that drains into or feeds into the descending aorta, which is of normal size, but we see severe hypoplasia of this left-sided aortic arch. Even the ascending aorta is kind of small. We can see the coronary origins. Remember, these kids will have heart rates around 120 beats per minute. But if you have a high temporal resolution scanner, you can actually visualize the coronary origins. There's one posterior coronary artery, and there is another coronary artery here anteriorly, and there may be a third coronary artery over here. So a little bit weird coronary origins, but that's what you would expect in somebody who also has DTGA in this case. As you can see, this is our pulmonic valve. This is the level of our aortic valve over here. So the aortic valve is anterior and rightwards relative to the pulmonic valve. So this is going to be DTGA. And we can appreciate this markedly dilated main pulmonary artery because it's responsible for flow to the descending aorta as well as the otherwise relatively well-developed pulmonary arteries bilaterally. That's why we have a large main pulmonary artery. We get to the level of the ventricles. The astute observers already observed that there's a septal defect, ventricular septal defect as well. And we can see that the right ventricle is markedly hypertrophied. And obviously it gives rise to our aorta. So it's going to have to push against systemic pressures or the right-sided ventricle. So I think we're past our time. So I think without going into too much more detail on these cases, just wanted to show a couple of cases where we can actually utilize prospective techniques and achieve great visualization in very, very small children of the coronary arteries even. So at least we can identify anomalous coronary arteries, really tiny hypoplastic vessels as well, and with very low radiation exposure. So I think I'm going to hand it back to you, Dr. Yogi. Thank you.
Thank you, Professor Suranyi. So, dear participant, we already seen like 4 cases that done with several protocol. We seen with one with retrospective cathing, and we see the one with turboflex, and we see 2 cases with prospective cathing. So, now we proceed to the Q&A session. So we already have 2 questions from Dr. Ido. And for another participant that want to ask a question, you can raise your hand. You can ask directly. If you are shy not to talk, to ask directly, you can type your question in the chat box. So I will read the question from Dr. Ido. Fantastic presentation, Professor Suranyi and Dr. Amal, very marvelous. So Dr. Ido want to ask, since we're talking about retrospective, turboflash, and the prospective, Dr. Ido asked about that. Do you have any suggestion to overcome the limitation of single source CT scanner in pediatric cardiac CT? Maybe because some, I think it's based on some hospital, they don't have dual DECT and they don't have spectrals. That's the first question. And the second question, for small neonates, do we need to recalculate the total fluid amount of the contrast that we're going to have? Because sometimes the neonates, they have limitation of fluid injection. Please, Dr. Amal, maybe you can answer first, and then we will ask for more from Professor Suranyi.
Okay. Thank you, Dr. Yogi, and thank you, Dr. Ido, for the question. And I think for the first question about the single source, we use also single source CT, and it depends on the CT actually. So we can use actually every CT minimum is 64 slice for pediatric. So that's why if we don't have a very fast acquisition time for CT, for example, like Prof. Suranyi mentioned earlier, so we can use protocol with retrospective ECG, but if we have CT that really fast, we can use prospective or even turbo flash, so in order to reduce the radiation. So at least our principle is ALARA. So we need to know more about the information for the clinician. So we need to understand our machine. That's the important thing. So single source also we can use to scan for a pediatric. So before we have single source CT with 128 slices and also 64 slices. So we use retrospective investigated, and also we also use prospective, but our scan we expand the scan. It's adjusted perspective that Prof Bali mentioned. So I use the technique before with my single source CT. That's the answer for number one, I think. And for number two, for small units, I also use same amount, so 1.5 milliliter per kg for contrast dosage, even for neonates. And I think I already talked with also my pediatric nephrologist, and when they say it's okay, then I will do the protocol as usual. So I think that's the important to have communication also with the clinician. And that's for my answer. Maybe Prof Suranyi can add.
Yes, I absolutely agree. I would just reiterate that even if you have just a single source scanner, it's worth attempting the scan. If you have a prospective mode, always aim for end systole because of the higher heart rates. In rare cases, if you talk to your cardiologist, it might be possible to give some beta blocker to slow down the heart rate. But I understand that's going to be very limited in some of these very sick kids. But if you're maybe dealing with a little bit older kids or a little bit, not that sick patients, you could consider discussing it with the clinician and give some beta blocking to slow down the heart rate. But I would still say that CT has very important things to offer. Like Dr. Amal mentioned earlier, the airways are always very important because in these patients with congenital heart disease, they might have airway complications or airway compression. So it's going to be still very much important to scan these patients. And the more posterior structures, like the pulmonary veins, are often very, very difficult to see with echocardiography. So I would still encourage you to attempt scanning these kids, and don't be afraid to use retrospective gating if that's the only, if you have a single source scanner and you have a high heart rate. That's what we used to do as well before we had the dual source scanners, like Dr. Amal said. I wholeheartedly agree with that in a very sick child, you may want to just go ahead and scan retrospectively, because the heart moves in a funny way, and sometimes some portions of the anatomy may be better visible in systole and others in diastole. So that would be my answer, and I agree. It's always very important to talk to the clinicians, nephrologists as well, regarding fluid. But if you have to, you can leave off the saline chaser, for example. You can just leave that off. Or you might have some streak artifacts, like Dr. Amal mentioned. The best is to give that three-phase injection protocol. But if you can't do that, it's still worth attempting just with contrast, or with contrast and then a contrast saline mixture chaser. So excellent questions. Thank you very much.
Thank you, Dr. Amal, Professor. So actually, do not worry if you only have the single source. You can still use the retrospective, and you can talk to the nephrologist about the contrast that you given to the patient, that maybe they have restriction in fluid. You can just talk with the pediatrician. So we going to the second person that asked the question tonight. It's Dr. Austin. Dr. Austin want to ask that he want to confirm how flash acquisition was made. Is it acquired by increasing the table speed? And the second question, with difficult cases like Fontaine heart or El Kappa, how should we decide which mode of scan to use? And can retrospective acquisition be used for all cases, even though there is increased radiation dose? And that's the question from Dr. Austin. Maybe Prof. Suranyi, you can answer first.
Sure. Thank you for the question, Dr. Austin. The flash scanning mode is primarily achieved by indeed increasing the table speed. So the pitch, in other words, is very, very high. The reason the scanner is able to do that is because of the configuration of two X-ray tubes and two sets of detectors, and thereby they can achieve this kind of complex scanning in very fast way. But partly it is indeed table movement, and partly it is the ability to acquire data very, very fast with this fast temporal resolution. The second question, the answer to your second question is it's going to be patient dependent. If you have the ability to change from retrospective to maybe prospective mode, I would still encourage you to do that in cases where that's sufficient to answer the clinical question. So you are correct in assuming that a retrospective acquisition is a catch-all. It will give you the most information about all of the cardiac cycle and probably the best chance of visualizing small structures, including the coronary arteries as well. But sometimes we have to use the LRO principle, or all the time we have to use the LRO principle, really is as low as reasonably achievable. So if your scanner has the versatility, then at least like I said, in our institution, if the specific question is, where do the coronaries originate? In the overwhelming majority of cases, we will use prospective triggering. And if it's just that small question. If the question is more about the veins, pulmonary veins, let's say, it might be sufficient to do prospective triggering. But if there is any question about valvular function, or if there is a clinical question about maybe right ventricular or left ventricular function, and obviously it's more applicable in older kids or even post-operative patients, then we will use retrospective gating or that adaptive sequential scan where we get a portion of the cardiac cycle that's sufficient for at least measuring right ventricular and left ventricular ejection fraction. So it's going to depend greatly on what the cardiologists are looking for. So obviously in an Al Kappa patient, anomalous left coronary artery from the pulmonary artery, with a very high heart rate, it's probably best to do a retrospective gating. But it's going to be very patient dependent. I don't know if Dr. Amal would like to add to that.
Thank you, Prof. Suranyi, and thank you, Dr. Austin, for the question. And I agree with Prof. Suranyi. And for a difficult case like Fontan, we have like a different protocol to scan the patient. So in terms of the dosage of the contrast, and also how to inject the contrast, because we need to have like venous phase during our scan period. So because I'm not using non-contrast phase in order to reduce my radiation, also because in a patient, for example, a congenital heart patient, before surgery, I'm not using pre-contrast because we'll directly using only post-contrast in order to reduce the radiation dose. But if the patient post-operative and I really need to know about if there's any lesion such as calcification or something like that, I need to scan with the pre-contrast also. But for the Fontan, I will, there's some types of how to do the protocol of the Fontan injection, but some protocols we will use like 2 IV line, and we will use like, before I'm using 1.5 milliliter per kg, but in Fontan, I will use maximize dose like 3 milliliter per kg. And I will use both IV line and half in the upper and half in the lower. So that's why in order to capture the artery and venous in the during one scan, that's my technique for the Fontan. But for the Alcapa, I agree with Prof. Suranyi because it's really difficult, and also you need to have a really understanding between radiology and technologies or a radiologist, because you really need to know about their capability, because sometimes they're afraid if they choose prospective, because if they miss the timing, or even they miss the scan, so usually I'm using for Alcapa is always retrospective in my hospital, because that's the reason why for a coronary artery anomaly, I'm rarely use prospect. So that's why I always use retrospective for the coronary artery.
Yeah, thank you, Dr. Rama. I hope that answer your question, Dr. Austin. So it already depends on the patient, what the clinical information, and maybe the facility that you have. And also we need to think about the patient radiation. And the last one, we also maybe the confidence of our teams to do in such cases. Maybe if we are not if we are not confident enough, we can use the most safe protocols, so we do not miss anything. So I think that's the question from Dr. Austin. Dr. Austin, you can ask more questions. You can have following question if you still it doesn't answer your question.
I think that's enough, Dr. Yogi. Thank you so much, Prof. Suranyi and Dr. Amal.
Thank you, Dr. Austin. Okay, do we still have a question from other participants? So I think they already okay. So oh no, it's not a question. So yeah. So we don't. I think we don't have more question. We are very. So yeah, no more question, right? Yeah. Maybe one little question, Dr. Amal and Prof. Suranyi. How about a patient? Sometimes we cannot get the IV access in the orbital, so we use the central venous access. Do we need to adjust the protocol for that case?
In our institution, we just use whatever we have. That's the short answer to that. So you don't stick a baby, especially babies or kids, for optimizing the injection for CT, and for smaller children, definitely we hand inject too. So to be careful. So, but I don't know if Dr. Amal has anything else to add.
Yeah, it's quite similar. If the baby only have like central venous catheter, usually probably we need to adjust the timing of the scan, and because we put the ROI in the ventricle, so we need to look carefully during the scan, and we need to really measure about the timing, scan time when we press the scan, and how long the machine will scan. So we need really to measure carefully about that. So I think we also can use central venous line, but we need to make sure and also inform consent first if something happened with the central venous, because we are using ejector, so we need to make sure the central venous is safe for ejector also. I think that's important.
Okay, thank you, Dr. Amal and Professor Suranyi. So I think that's actually the end of our session. So we are very grateful to have you two here with us, sharing with us. I think I have one more information for all the participants. Maybe it's a little bit spoiler. Professor Suranyi wearing batik right now. Maybe it's a sign of Professor Suranyi will go to Jakarta in February. And PRODIGEE team, we will held a workshop with Professor Suranyi, and we will inform you later about the registration information, and you can join us in 23rd of February for the workshop from the PRODIGEE. So maybe before we close this session tonight, so we can take a picture together for any participant that you are still in front of camera. Please open up your camera so we can take a picture. Please, Pinkan, can you help me to take the picture?
Okay, thank you for all participants. So you may open your camera, and so we have 3 pages here. So I'll start with page 1. Okay, so smile, 1, 2, 3. Okay, so we proceed to the next one. Okay, 1, 2, 3. Alright, so for the last page. Cheers, so 1, 2, 3. Okay, so that's all. Thank you.
All right, thank you, Pinkan. So I really hope that this very exciting session tonight will give you more knowledge about the pediatric cardiac CT, so you will be more confident in dealing with these cases. So for the closure of this session, maybe I, as the representative from the PRODIGEE team, I say thank you, Professor Suranyi and Dr. Amal, to sharing for us very invaluable knowledge and interesting cases. So I hope we can meet in another session. And also for the participant, please do not miss our next webinar and workshop, especially at the February 23rd. We will have a workshop and you can join. For the information, we will inform you later. Okay, thank you, everyone.
Thank you so much.
Thank you so
Great
much.
privilege and honor. Thank you very much. Thank you all for being here.
Good morning, Professor.
Thank you, Prof. Ali.
Hey, Dr. Heltera. Good to see you.
We will welcome
thank
you
you
in
all.
Indonesia. Huh?
I'm very excited. Thank you. Hopefully it'll all work out. Yes. Thank you.
Yes. See you. Thank you
Great
so
session.
much.
Appreciate the opportunity. Thank you all. Bye-bye.
Thank you.
Bye-bye.